Welcome to this explainer. Today we're diving straight into the granular physiological details and the multi-step management exceptions of pediatric surgical abdomens. We're not doing a standard textbook review here. Instead, we're focusing entirely on those subtle make-or-break variables that dictate massive shifts in clinical management. You know, those high-stakes scenarios where just a slight change in vital signs completely rewrites your whole algorithmic approach. Let's get into it.
Here is our clinical algorithm roadmap for today. 1. The bilious emesis fork. 2. Intussusception reduction limits. 3. Pyloric stenosis metabolic correction. And 4. Clinical reconciliation traps.
Module 1. The bilious emesis fork. Malrotation with volvulus versus duodenal atresia.
To really understand the emergency here, we have to rewind to the embryology. Midgut malrotation is fundamentally driven by a failure of the normal 270-degree counterclockwise embryonic intestinal rotation. So what happens? This embryological failure leaves the cecum in a totally abnormal position and basically tethers the midgut to this dangerously thin stalk of mesentery. And that narrow mesentery base is a setup for disaster. It leaves the midgut highly prone to clockwise torsion right around the superior mesenteric artery. That torsion is the spark that sets the stage for volvulus, rapid ischemic necrosis, hematochezia, and ultimately full-blown peritonitis.
Now, bilious vomiting in a newborn isn't automatically volvulus. While both conditions present with bilious emesis, you have to immediately contrast the ischemic torsion of a volvulus against duodenal atresia. Duodenal atresia, as you'll recall, is a failure of the lumen to recanalize after the solid phase of intestinal development. It usually presents with a scaphoid abdomen, the classic radiographic double bubble sign showing air in the stomach and duodenum, but absolutely no distal gas, and is heavily linked to trisomy 21. Think of it this way: volvulus is a terrifying vascular emergency. Atresia, that's an obstructive anomaly.
Take a look at the classic corkscrew appearance right here. You can clearly see the displaced bowel anatomy. Now, the upper GI contrast series is the absolute gold standard for nailing down the diagnosis of malrotation with an obstructive volvulus. But, and this is a massive but, utilizing this incredible diagnostic tool is entirely contingent on one thing. Your patient must meet strict physiological criteria to safely undergo the study.
And that brings us to a major execution trap. If your infant is hemodynamically stable, great, the upper GI series is your next step. But what if your 3-week-old infant is tachycardic, hypotensive, and showing signs of abdominal guarding? In that scenario, you have to completely bypass these diagnostic imaging decoys. An unstable patient mandates an emergent exploratory laparotomy or laparotomy, specifically the LAD procedure, to prevent total midgut infarction. Misinterpreting hemodynamic instability and thinking it's safe to send them for a contrast series, well, that will literally cost you the patient's bowel.
Moving right along to Module 2. Intussusception, pathomechanics, and reduction limits.
Stepping out of the newborn period, we enter the 6-month to 3-year window where episodic, colicky pain dictates our next branching logic pathway. Intussusception is the telescoping, or invagination, of a proximal bowel segment, the intussusceptum, right into a distal segment, the intussuscipiens. We typically see this happening proximal to the ileocecal valve. As the bowel telescopes inside itself, it drags its mesentery right along with it. This creates intense venous congestion and mucosal shedding, which gives us the classic triad: intermittent severe abdominal pain, vomiting, and those hallmark current jelly bloody mucus stools. Just remember though, you're not always going to see all 3 of these classic signs in every single patient.
So what's actually causing this invagination? Well, it's often idiopathic in that standard 6-month to 3-year bracket, frequently secondary to enlarged Peyer's patches from a recent viral URI. But we have to proactively hunt for specific pathological lead points in atypical presentations. If your patient falls outside that normal age window, your differential needs to expand immediately. You've got to start thinking about a Meckel's diverticulum, intestinal lymphoma in older kids, submucosal hematomas, which are classic for Henoch-Schönlein purpura, polyps, or even inspissated stool if you're dealing with a cystic fibrosis patient.
Right here we can see the beautifully classic diagnostic target sign on ultrasound, which is incredibly sensitive for intussusception. The moment you identify this right upper quadrant mass, your clinical reflex should be to utilize an air insufflation enema. The beauty of the air enema is that it pulls double duty. It's the preferred method for both rapid diagnosis and immediate therapeutic reduction. It's a fantastic way to bypass the need for surgery in uncomplicated cases.
However, that pathway has a hard, unyielding physiological boundary. If your 10-month-old patient suddenly develops a rigid abdomen,
clinical shock, or you spot free subdiaphragmatic air on a plain film, pneumatic reduction is absolutely contraindicated. The presence of any of these hard signs turns pneumatic reduction into a catastrophic blowout risk. At this point, the enema is completely off the table. You are mandated to transition immediately to surgical resection.
All right, Module 3, Hypertrophic Pyloric Stenosis and the Metabolic Correction Rule.
Now we're shifting from bilious ischemic threats over to the distinct profile of non-bilious progressive gastric outlet obstruction. Hypertrophic pyloric stenosis usually shows up between 2 to 8 weeks of age. You'll see forceful, non-bilious projectile vomiting right after feeds, often paired with a palpable olive-shaped mass in the mid-epigastrium. The strict diagnostic parameters here rely on a targeted sonographic evaluation. Specifically, you're hunting for thickened pyloric musculature, looking for a thickness greater than 3 millimeters, and an elongated pyloric channel measuring greater than 14 millimeters. Because that relentless projectile emesis dramatically drains the body of hydrochloric acid and potassium. It kicks the renin-angiotensin-aldosterone axis into overdrive. This drives a profound hypokalemic, hypochloremic metabolic alkalosis. And this specific chemical derangement creates an absolute surgical mandate. Listen, pyloric stenosis is never a surgical emergency. It's a medical emergency first. You absolutely must hold the scalpel until aggressive IV fluid resuscitation with normal saline completely normalizes the infant's serum electrolytes and acid-base metrics. Only after that normalization can you safely proceed to the delayed surgical ramp step pyloromyotomy.
Now, the timing exception here is a classic trap that you just have to avoid. Let's say you encounter an infant with an ultrasound-confirmed stenosis, a serum chloride of 84 and a bicarbonate of 36. If you push for an immediate pyloromyotomy, that is a massive critical error. Why? Well, because operating in the setting of uncorrected, persistent metabolic alkalosis severely depresses the central respiratory drive. If you do that, you are basically guaranteeing severe, potentially fatal perioperative apnea the second that infant is subjected to anesthesia. Safe, definitive surgery strictly follows the metabolic normalization mandate. No exceptions.
And finally, Module 4, Clinical Reconciliation and High-Level Traps. Let's tie this entire decision architecture together by systematically cataloging the most dangerous clinical deviations we've covered today. We really must ruthlessly avoid these easily missed parameters. The major traps are essentially threefold. First, misinterpreting hemodynamic instability as somehow being safe for a contrast series in a suspected volvulus. Don't do it. Second, attempting diagnostic or therapeutic pneumatic reduction on an intussusception patient who has a rigid abdomen or free air. And finally, prioritizing a scalpel over saline in a profoundly alkalotic infant with pyloric stenosis. Recognizing these hard boundaries ensures you don't turn a manageable pathology into a total iatrogenic disaster. As you navigate these multi-step management exceptions, just remember that parsing tissue ischemia, kinetics, and fluid shifts isn't just about knowing the surgical technique itself. It's really about mastering the exact moment an intervention becomes an absolute necessity and having the clinical discipline to hold off when it isn't. When you assess a pediatric surgical abdomen, always ask yourself, what singular low-frequency variable dictates your boundary between a diagnostic decoy and an emergent surgical pathway? What is the true physiological state of my patient right now? Thanks for joining me on this explainer. Keep questioning those clinical boundaries, and I'll catch you in the next one.